Now, diabetes mellitus gets its own entire chapter, whereas a lot of our endocrine disorders just got a slide, right? Obviously, various kinds of diabetes mellitus are very common in our culture, especially type 2 diabetes mellitus, DM2. So let's go ahead and get into it. So think in terms of energy nutrient metabolism. We're really talking about glucose and fat. The reason fat is up there, by the way, is because we have something called interconversion of nutrients, where we can convert fats into glucose in some cases. But really, when we're talking about diabetes, we need to think about glucose metabolism. So glycogen is a way that your body stores glucose. Glucose is the monomer for carbohydrates, right? That's the one we're at least thinking about. The way your body stores it usually is in the form of glycogen. And here's glycogen over here. Let me get my cursor working again. Oh, of course, it's gone. All right. It's like 50-50 today. There's our glycogen molecule. Each one of these little dots up here, that's a glucose molecule. So when you're talking about glucose metabolism in the storage form of glycogen, you're saying when you need more glucose, you can break off more glucose from this molecule. And when you need to store glucose, you can assemble it into a glycogen molecule. That's what your liver does when it's doing storage of glucose. It's transforming it into glycogen. And then when you are in a fasting state, when you have not eaten food recently and you need your blood sugar to be increased, then you can break down glycogen, and that's going to be called glycogenolysis. Lysis of glycogen, like breaking off a piece of a Kit Kat bar, because that's how much energy you need. You like it? It's like a spirally Kit Kat bar. Yeah, I like it too. And then if you're going to use other nutrients like amino acids or fats, then you can make new glycogen or new glucose, and that's going to be gluconeogenesis, formation of new glucose. So that's all going to be part of our glucose metabolism. How we get it is either from nutrition or from stores. We can interconvert nutrients, or we can break down glycogen to increase blood sugar. And that's going to be under endocrine control, right? We already had this image way earlier today. Let's go back to this real quick because it is relevant right now and to the worksheet that I have you doing. It'd be cool if I could see these instead of them being entirely blank. All right, well, that's not existing. I'm seeing the same thing you guys are seeing. It's just all blank slides right there. That's great. Oh, good. This is working super well today. Okay, there we go. I'll go back to it later, but we had that slide about synergism and blood sugar levels based on not just insulin, glucagon, but also cortisol. Epinephrine had an impact, and they had synergistic effects on blood sugar, not just additive effects. That slide gave you other hormones that were responsible for increasing blood sugar. Now again, hormonal regulation. Insulin is synthesized from the beta cells of the pancreatic islets. Old school term for that is islets of Langerhans. You also have alpha cells producing glucagon. So these are actually antagonists. Insulin decreases blood sugar by initiating uptake of glucose into the cell. So think of that in terms of compartments. This works for you guys for bones and calcium. So I'm going to do the bloodstream here with the glucose molecule, and then a cell over here. If the glucose is in the bloodstream, it's not in the cell. If the glucose is in the cell, it's not in the bloodstream. So when we say lower our blood sugar, we need uptake of glucose into the cell. Now that glucose is in the cell, right? Yep. So insulin lowers blood sugar by initiating uptake of glucose by cells. And glucagon is actually going to raise blood sugar by initiating, for example, glycogenolysis. That make sense? Glycogenolysis initiated by glucagon. So you release glucagon, that's going to raise your blood sugar. You're going to take your storage forms of sugar and you're going to release it into your bloodstream. So it's not that that glucose is coming back out of the cell, At least not your tissue cells, it's that it's coming from your liver. Does that make sense? Because that's where the glycogen is. Liver, what's up?
Glycogenolysis is raised by what?
Glycogen is in the liver, to simplify it.
Glycogenolysis?
Glycogenolysis is breakdown of glycogen to increase blood sugar. So homeostatically, you eat some food, your blood sugar goes up, your pancreas detects your increased blood glucose and releases insulin. Now the insulin, physically what it does is it transports carrier molecules to the plasma membrane of the cells of your tissues. Carrier molecules that are going to take that glucose into the cell. Okay. I do have a picture for this coming up. It's also going to inhibit gluconeogenesis, formation of new glucose, and it's going to enhance fat deposition by preventing fat breakdown, which is lipolysis. Break these terms down and make them make sense to you because they translate. Really like it if my laser pointer would work. Sadly, it does not. All right, and I already said this, but I'm going to say it more cohesively because I'm kind of stuttering around things right now because I've been going for a long time now. Hormonal regulation. In a fasting state, glucose is produced by glycogenolysis, gluconeogenesis, and lipolysis. So you haven't eaten anything for a while, but you still need sugar, so you take it from existing stores, right? Glucagon is the hormone responsible for glucose production in the fasting state. Other counter-regulatory hormones, corticosteroids, growth hormone, catecholamines, augment glucose production. So between glucagon, cortisol, growth hormones, epinephrine, norepinephrine, those things will act synergistically to increase blood glucose levels. And remember our synergism chart, it's not additive, it's synergistic. 2 plus 2 plus 3 equals 50, right? Do you guys remember that? You looked like for a second like you didn't remember that. Okay. It's slide 5, thank you. It's not working on mine, so I'll take your word for it. Okay, so there's more than one type of diabetes mellitus. We saw diabetes insipidus, and that had nothing to do with glucose. That was just polyuria polydipsia because of problematic ADH, right? Now, the reason that was still called diabetes is because most of our diabetes mellituses are going to come with polyuria and polydipsia. Excess of thirst, drinking water, peeing it out. That's what they have in common. That's where that phrasing is coming from. Mellitus is specific to the insulin and glucose pathways, but at different places. There's also prediabetes, and there are gestational diabetes, so other varieties of intermediate forms in some cases, or conditional forms of diabetes mellitus. So type 1 is the immune-mediated or idiopathic. So I really consider it an autoimmune disorder. It seems to be that your immune system is impacting the insulin receptor. So here's your insulin receptor. Let me do this up here. Here's your insulin receptor. This is metabotropic. It's not that this is an ion channel that's going to let glucose through. It's that this is a receptor that's going to cause transposition of a carrier molecule to the plasma membrane. This would otherwise be, oh, there's a glucose, sorry. That glucose transporter would normally be stored inside the cell. In the presence of insulin binding to this receptor, this will be plopped onto that plasma membrane. Otherwise, it is absent. Does that make sense? This is why I made you learn the word metabotropic and carrier molecule and transporter interchangeably. That's why we've been doing that since day one. Okay, so in the case of type 1 diabetes mellitus, what's happening is non-responsiveness of, sorry, maybe make sure I'm saying this. I did that completely wrong. I'm sorry. Type 1 diabetes is autoimmune destruction of beta cells. So the beta cells are secreting what? Insulin. Now, if we are destroying the beta cells because of our immune system, then we can no longer release insulin. So the receptors in this case are fine. It is the insulin that is not being synthesized in this scenario. And again, there are some idiopathic forms. They do not have antibodies against the beta cells, but there is an autoimmune form. This is going to be an absolute insulin deficiency. They are going to completely lack their own endogenous insulin. They may also overproduce glucagon. Either way, we're going to have elevated blood glucose levels. There's going to be polyuria, polydipsia, there's polyphagia. They're going to be very hungry. One thing that's going to happen, as you cannot use glucose for energy metabolism, we're going to use fatty acids instead. What's up? Okay, so here's the thing. Remember cellular respiration pathway. We usually start with oxygen and glucose, right? It turns out you can also put fats into that cellular respiration pathway. It starts at a slightly different place, but the result is the same. You can make ATP from your fats. So free fatty acids, FFAs. The process of doing that, however, is going to produce measurable ketones. This is the cellular byproduct of metabolism of free fatty acids. And that's going to potentially lead to diabetic ketoacidosis. And I know for a fact that you're going to care a lot about the process of diabetic ketoacidosis. There we go. So type 2 diabetes culturally is going to be more common, and it is on the rise due to the rise of obesity. There is a massive issue with cause and effect on this. We don't officially have cause and effect here. That having been said, the general thought process is people gain weight, they are exposed to a lot of sugar as they gain weight, and as a result of the overabundant sugar, the insulin receptor becomes desensitized. That's one thought process. It could be the opposite. Same with hypothyroidism. It could be that an endocrine disorder leads to weight gain. There are some Swedish studies that show that controlling diet and losing weight and becoming a much healthier person is reversing type 2 diabetes. We do have that. That having been said, no American study has shown that we can permanently cause lifestyle changes that result in reliable weight loss. It's much more complicated than lose some weight. That's not going to help people to say it that way, for one thing. Okay, so type 2 diabetes mellitus, this is tissue resistance. This is the receptors becoming insensitive to insulin. You can release all the insulin in the world. The insulin receptors will not respond to them, and they will not put the glucose transporters into the plasma membrane. Therefore, no matter how much insulin you have, your blood pressure, or blood sugar, sorry, should still be high, because it's not being transported into cells. Make sense? Okay. Now, as the disease progresses, insulin production may be impaired. There could be a negative feedback loop where we're going to downregulate insulin. So we can still give people with type 2 diabetes insulin as part of their treatment regimen. Is it going to be as effective? No, because they already have insulin. It's the receptors that are the problem. I keep using this as though it's connected, and it's not. This is Wilford Brimley, and this is Wilford Brimley cat. And he was in a rather famous commercial. Is anybody familiar? In which he pronounces it diabetes. But anyway, that's the only reason Wilford Brimley's up there, and the cat. So risk factors: being female, being obese, aging, sedentary lifestyle. Ketoacidosis is going to be less common in type 2. Doesn't mean it's not going to exist. And again, even if you're not in diabetic ketoacidosis, there can still be hyperglycemic hyperosmolar coma, meaning there's really, really elevated blood sugar and it's causing fluid shift problems. Making sense? Yes.
Is there a coma for type 1 as well?
For DKA, absolutely. Yeah. Yeah. Okay, gestational diabetes. If somebody was maybe pre-diabetic or prone to diabetes before their pregnancy, with all of the crazy hormonal and blood pressure and even weight changes that happen during pregnancy, it can be enough to tip somebody over into gestational diabetes. And often that's reversible when pregnancy is over. Not 100%, but it can be reversible after pregnancy. So severe obesity, history of gestational diabetes. If you had gestational diabetes with your first pregnancy, your second pregnancy, you are also very likely to develop gestational diabetes. Offspring with a high birth weight, presence of glycosuria, sugar in urine, and then of course strong family history of type 2 diabetes. So this would be a variation on type 2. This would be tissue resistance with onset of pregnancy. And it's always on a continuum, so if somebody is not quite diabetic, but they are showing impaired glucose tolerance, decreased glucose tolerance, not quite the same amount of glucose tolerance as a statistically normal person, then that's pre-diabetes. And again, if we catch that and institute lifestyle changes, then we can prevent the worsening and progression into type 2 DM. The complications of this, if it's unmanaged, type 1 or type 2, would be acute hyperglycemia, too much blood sugar all of a sudden. It could be related to sudden nutritional changes. I just decided to eat a bag of cookies all of a sudden. Could be due to inactivity. I took a bunch of carbs thinking I would need them, and then I stayed in instead. Or inadequate use of anti-diabetic medications. I'm non-compliant with my diabetes protocol. Now, there's also hormonal changes that go with our circadian rhythm, and it is typical to have elevated cortisol just before you wake, and that again is synergistic with blood sugar. So that elevated glucose, elevated cortisol in the morning is going to mean that somebody could go into acute hyperglycemia, specifically in the morning, just because of their normal hormonal circadian rhythm. Another issue of this is going to be being more prone to infections. I thought I had a slide for this. Maybe I don't. Maybe the slide comes later. Why is somebody more prone to infections with various forms of glucose-based diabetes? Sugar is dirty. Is that a microbiome statement?
Yeah.
Karen said it? Sugar is dirty. So sugar does a few things. First of all, bacteria really likes sugar. Second of all, and I don't know how much of this you've gotten, sugar is inflammatory. And it's big. It's pro-inflammatory. You're actually going to interact with the epithelial cells of your capillary beds and cause inflammation. And I do have a cellular process for that somewhere. If it's not here, you'll see it later, if you're interested in the cellular process of why glucose is inflammatory. So you've got an inflammatory environment and you've got some happy, hungry bacteria. And so, yes, you're going to be more prone to infection. Sure. I'll take that. So glucose is so big that it crushes everything on the way, potentially. It's a 6-string carbon chain, or a 6-carbon chain is a better way to phrase that. It's not as big as your red blood cells, but yeah, if you've got enough of it, it's going to be pretty destructive. Of course, there's the slide I was thinking of. There's our cellular process for showing inflammation of the endothelial cell of the capillary bed. So again, this was acute hyperglycemia. You can also have that continue into chronic hyperglycemia, especially like long-term neglect of your diabetic state. Maybe you haven't been diagnosed yet. Maybe you haven't been diagnosed properly. Maybe your medication regimen is insufficient. This is going to result in systemic changes. You're going to have a number of compensatory mechanisms, and this is going to affect everything, especially your cardiovascular system. When you think about long-term hyperglycemia and untreated diabetes, I want you to think about all of the organs and all of the places in your body that have a significant role of microvasculature. I want you to start thinking of your retina, your kidneys. I want you to start thinking of your brain, right? Everything. I mean, your capillary beds are everywhere, but there's certain things where the manifestations become very significant if suddenly you're blind. Diabetic retinopathy. If suddenly your kidneys are failing, right? That's going to have a massive impact on your health. So macrovasculature, we have damage to large blood vessels that can lead to cardiovascular disease, peripheral vascular disease, maybe a stroke. And then microvasculature, we can have a retinopathy, a nephropathy, and can lead to blindness and renal failure. And obviously that will in fact impact all of your microvasculatures. Just those are going to be the ones that are very obvious, life-altering, can potentially kill you. So we want to control blood glucose levels. And we also want to prevent complications. We want to prevent sequela. Sequela. No, that was good.
Previous recording.
I hope so. Sequela. Let's do it again. It's my job to make creepy recordings. You remember it when I say creepy stuff. So it works out. So again, we can do diet, exercise, medication, and hygiene practices. Why hygiene practices? Why do we need to look at our feet? You may have a diabetic neuropathy. You may have lost sensation to the extremities. If you had some kind of small cut on the sole of your foot, normally you would clean it, you'd pay attention to it. And in this case, you may not. You may not be aware of it. Ulceration may occur. Even if you're aware of it, you've got a breeding ground for bacteria because you've got elevated blood glucose. So it's going to progress much more quickly. Yeah, so diabetic shoes, diabetic socks, foot care, wound care. And what's the sequela that they're at risk for if you've got untreated ulcers? So diabetic ulcers leading to necrosis and amputation. Sepsis as well. Absolutely. Insulin will be very effective for type 1 diabetes mellitus. Insulin will be somewhat effective for type 2 diabetes mellitus. And again, this is kind of farm, so I'm not going to really go into the different types of pharmacology and interventions for it, but yeah, you've got rapid-acting insulin, you've got short-acting, intermediate, long-acting insulin. Have you guys heard of the artificial pancreas that was developed open source? Really super cool. So it's like a machine that was permanently attached, permanently detecting blood sugar levels, and permanently releasing the necessary insulin levels to keep the insulin levels perfectly aligned to what that person needed. And it was developed open source. It wasn't a private company that developed it. It was just people coming together to make it happen. Cool, right? Artificial pancreas. It would help people. It's out there. I feel like it's experienced legal troubles, but I haven't read up on it in a while. Because it's not like the medical community made it entirely. A street device. Going to be a cyborg from the back alley. Again, I don't know 100% about it. There might be a cooler story there than what I just said, but yeah, that's where we should be heading with this, is making sure people have perfectly controlled insulin and glucose at all times. And that's the way it should be, instead of upping the price of insulin every month. Mic drop. Okay. So we want to mimic normal insulin release, and some things are better than that than others. Hypoglycemic complications. Maybe as diabetic, you're giving yourself insulin, but you have to be giving yourself insulin in accordance with the carbohydrates you're taking in, right? So maybe you gave yourself too much insulin, or maybe you didn't take enough food for the amount of insulin you gave yourself. Maybe you surprised yourself by needing to run across town and you didn't prepare yourself with the right amount of, you already took too much insulin for that activity. or maybe you just overdosed your insulin. Tremor, diaphoresis, palpitations, anxiety, hunger, visual disturbances, weakness, paresthesia. Some people will be unaware of their hypoglycemic or hypoglycemia. This could be like a general term. You can just say, oh, I'm hypoglycemic unaware. I have no idea when I have low blood sugar. I am the opposite of that. I get hangry. I know when I've got low blood sugar. That's why I went out and got a mocha latte earlier. There's a little crash coming. So not everybody who is on insulin and monitoring their glucose levels will be very aware of what their blood sugar level is. It takes sort of time and training and frequent testing of glucose levels to figure out how people feel, how an individual feels. Now, if somebody is injecting insulin, a number of things can happen as a result of that, especially if they're not rotating injection sites. At the injection site, there could be lipohypertrophy. At the injection site, you're getting all of the insulin, right? That means you're getting all of the uptake of glucose into those cells, and that means we're going to store that as fat in that area. It's too much glucose, right? We're going to store it as fat. Lipoatrophy, there could be some destruction of subcutaneous adipose tissue as well. Insulin edema can occur, and then insulin resistance. If this process continues with the insulin resistance, giving them more insulin can just make them more resistant.
Would it just be like
I think it's noticeable. Again, I've never seen it clinically. I just understand it physiologically. Yeah, we can look up lipohypertrophy. I imagine it would be a noticeable bulge in an area. Right, if somebody's just already chunky in the abdomen. I imagine it's a smaller bump, but I don't know. But if you're rotating sites, it shouldn't be an issue. Okay, we're actually kind of wrapping up here. We're at almost 70 out of 87. It's not bad, 17 to go. We'll wrap it up this hour. That's good. Nutrient metabolism. Honestly, there's going to be a lot of overlap with this in your nursing courses. There's nothing that I have to give you here that stands alone. That should be otherwise like really surprising. Again, we're talking about the metabolism. We're talking about nutrition and nutrients and the way our body uses them, the way we break things down and build them up into components for the cell, the way that we use energy and metabolism to make ATP. And the rate at which you do that is called your basal metabolic rate. So normal basal metabolic rate is about a kilocalorie per minute. And now I want to clarify something kind of ridiculous happening here. Kilocalorie is the scientific term for what we colloquially knew as a calorie with a capital C. Yes, I know. So if you look at nutritional facts on anything you're eating, if anybody's got something with nutritional facts, look on the back and it'll say calories, and it'll say a capital C. And that's the same as kilocalories, which is just metric. It means 1,000 small c calories. Yeah, it's weird. Yeah, exactly. Cubic centimeter and milliliters are the exact same thing. It's just colloquial. Calorie with a capital C equals a kilocalorie. So colloquially, we're burning a calorie per, what do they say, minute. Medically, we're burning a kilocalorie per minute. And again, that's resting, right? Many factors affect basal metabolic rate. Obviously, your metabolic rate is determined by your thyroid hormone, by your muscle mass, by your activity level. All manner of things are impacting your hormonal milieu, obviously. We just wrapped up hormones, but we're still being impacted by hormones. Now, the good news is we've already done our macromolecules of life. You know that carbs are going to be built out of glucose monomers, and this is the polymer. Your textbook's going to get a little simplistic about nutrition here, saying that about 50% of your diet should be carbohydrates. Again, that's for a typical healthy person, but people shift these numbers for fad diets. People shift these numbers for illnesses. People shift these numbers for all kinds of things. Usually a fad diet is literally just shifting the percentages of carbs, fats, and proteins. When you get down to it, or what's it called? What's the new one with the fats? Keto diet, yeah. And now you know what keto is about, right? We're inducing ketosis. We're inducing breakdown of free fatty acids. And yes, your ketones are going to go up if you're on this diet. Yeah, if you eat any carbs, you're not going into ketosis, and you're eating a lot of fat, which is very energy dense. Probably, yeah. Killing your liver, your liver is synthesizing the bile salts that are going to help you break down the fats. But that bile is going to be stored and concentrated by your gallbladder, and which is why I'm predicting that 5 years from now, everybody's having their gallbladder out. You've heard it here first. When you see that article in 5 years, you're going to be like, Reeves was right. Yeah. Okay, so carbohydrates, it's simplistic to say that 50% of your diet should be carbs. There's actually a lot of argument against that much of your diet being carbs. And actually there was literally a conspiracy by the sugar lobby to increase your recommendations for a daily intake of sugar. That literally happened for about 30 years. I'm not joking. So that number's probably high. Lipids, like I said, very dense energetically. By weight, you've got twice as many calories and fats as you do in your other nutrients. So just a chunk of cheese is going to be more calorie dense than the same chunk of something else. Let's see. And again, your liver is going to be what you're relying on for lipid metabolism, and then that's going to be sent to your gallbladder. So if you are increasing your fat intake, you are going to make your liver work harder, and you're going to make your gallbladder store and condense a whole lot more bile. And then proteins, as we know, are great. We need a number of essential amino acids and when we say essential amino acids, we mean amino acids that we cannot interconvert on our own. We can't take other proteins and make it into these amino acids that we need. We need to get them from the diet. So this is probably the one where it's so unique that you can't interconvert. You can't compromise on protein like you can on lipids and carbs. It also contains nitrogen, which means this is the one that you're going to get nitrogenous wastes on. So even though this is probably the one we can compromise on the least, it's going to be the one that's most problematic for troubled kidneys. It's like you can't win, right? Now, obesity. I'm going to spend this entire time ranting about how terrible your textbook is for BMI. Are we ready? Okay. BMI was never intended to measure obesity. That was never the intention of BMI. It's very bad at predicting the health of overweight individuals. And that's not in your textbook, and it should be. Good? We're good? We're clear on that? What BMI was for was detecting the health of underweight individuals, for example, in famine states. If a region is experiencing a famine, we can measure a person's height versus weight, and we can use the BMI scale to say how much in danger are they of starvation. It's excellent for that. The reason it gets used for obese people is that it's a lot easier to measure height and weight and put you on a scale and your doctor to tell you to lose some weight than it is to do a full physical assessment of you. And your primary care physician does not have the time to do a full physical assessment, pinch your skin, see how much muscle mass you have under there, have you run a mile and see how capable you are of that. That's not going to happen in your doctor's office. Instead, we do it to grade school students, exactly. I also want to say, when I started writing the differential diagnoses, I went to a couple of books on the topic. They should be in our library now. On how to do differential diagnosis, and I opened up the chapter about weight gain, and the first line of the chapter on weight gain for differential diagnosis: despite patient reporting, the most common cause of obesity is excess intake of calories. And then it spent 2 pages telling me about 500 different disorders that lead to involuntary weight gain. Yeah. So we still have this overall insight, this overall thought process of somebody's lying to me about their health. Doctors are still being trained that if you are overweight, you are lying about your health and how healthy you are and how active you are and what you're eating, even though we admit that there's a million things that could cause a person to be overweight. Yeah. And that pissed me off too. So, oh, another thing, then this is brand new and it's not going to be in your textbook. Bariatric surgery. What we found is that it's not removing parts of the stomach, it's stapling parts of the stomach. So we've been doing bariatric surgery for very obese diabetic people for a long time, and we know that it has good outcomes for reversing type 2 diabetes. That's excellent. What we've also very recently found is even if a person is not overweight, but they have type 2 diabetes, and we do this bariatric surgery, we can still reduce their diabetes. It's not about the weight gain, is what that tells us. It's about the insulin resistance. Something that we do not understand about stapling the stomach is having some kind of endocrine effect that does reverse diabetes. But currently, health insurance is not going to pay for a normal weight individual to get bariatric surgery, even though it is literally the cure for diabetes. Cures diabetes, reverses it.
Wow.
Type 2.
But don't you have, but it also comes with like its own set of problems. Like it's
Oh yeah.
Scary.
It is a scary, yeah, it's a scary surgery. There are possible complications for sure. But it's really promising and we need to get on this, is what I'm saying. So most absorption happens in the small intestine, not the stomach. So maybe there would be probably less pepsinogen release, so less breakdown of certain proteins, but you still have proteases from the pancreas. B12 absorption. So you can do lots of people are lacking B12 anyway. We've got B12 shots. I'll take that one over diabetes, personally. Yeah. Okay. Again, so your textbook is going to say key cause of obesity, excess intake of calories, elevated BMI. I'm just saying that's a little bit lacking in nuance and tape. Now, we live in America, and American food is highly processed and very, very calorie rich. It is really hard to eat an American diet and be in a normal calorie range. It's also problematic how we report caloric needs. On the back of that label, it's based on a 2,000 calorie a day diet. That 2,000 calories is an average between male and female, which means it's not appropriate for either males or females. Women should be on significantly less than 2,000 calories a day. Average men should be on significantly more than 2,000 calories a day. It is so individualized. Yeah, athletes would be on 5,000 calories a day. Something like Michael Phelps was eating like 5,000 calories a day during the Olympics. Yeah, like for breakfast he would have 5,000 calories. Yeah. Yeah. And then of course if you're like my partner and you've got mild hyperthyroidism, then yeah, you're going to be on 3,000 calories a day. All right, another weird thing that your textbook is about to say is characteristics of metabolic syndrome, not quite about obesity anymore, but related. Increased amounts of abdominal adiposity, which they're going to use this vocab word android habitus. That's the same thing as this down here. That's android habitus. It's just a weird phrase for abdominal adiposity. You have fat around your belly. That's the android habitus. If you are into like fashion design, we mean apple-shaped. There are other terms aside from android habitus. Hypersthenic would be synonymous with android habitus. These down here I took from another source. This is about radiology down here. So hypersthenic versus hyposthenic versus asthenic. These are phrases that radiologists use to determine the probable location of different organs. Back in A&P2, I taught you, here's the position of the large intestine. You have an ascending, transverse, and descending colon, and they will be located in this position in the peritoneal cavity. And here's a fun fact that's true for almost nobody. Hooray! So this is just something radiologists know about, that if you're apple-shaped hypersthenic, then you're going to have pretty much that arrangement of ascending, transverse, descending. But if you are like let's see, there's asthenic, there's pear-shaped. If you're pear-shaped, probably your transverse colon is down here, closer to your pelvic cavity. And that's where they're going to go look for it if they're a radiologist. Likewise, look at the position of the gallbladder. Hypersthenic, if you're apple-shaped, your gallbladder's up here, probably underneath your liver. But then for asthenic, your gallbladder's probably pretty low down. Weird, right? Yeah, not even remotely covering all the body types. No, of course not. Hyposthenic being like the triangle, like wider shoulders, narrower hips. And I don't remember what sthenic is supposed to be. I think it's just kind of straight. Banana shaped. I don't know what that is. Okay, metabolic syndrome, if you're apple shaped. Increased free fatty acids, insulin resistance with or without type 2 diabetes evidence. Low serum HDL, hypertriglyceridemia, you have a lot of triglycerides, and hypertension. Puts you at an increased risk of cardiovascular disease, myocardial infarction, and death. Oh, I keep clicking on this like it's connected and it's not. Okay. Okay, did I keep this one? Physiological stress, such as cortisol. When you're physiologically stressed out, there's going to be a cascade of events in your body. You're going to be activating your sympathetic nervous system. You're going to have a high metabolic rate. Doesn't seem like it because you might be gaining weight because of cortisol, but you've got a high metabolic rate. Some people when stressed lose weight, some people when stressed gain weight. It's individualized. I know, right? Sustained catabolism. You've got high metabolic rate, you're going to be breaking yourself down, not necessarily for the food you eat. Yeah. Hyperglycemia, your blood sugar level is probably high, which means it's going to be a little pro-inflammatory. Salt and water retention. We're more likely to get glucose from gluconeogenesis. We're going to transform other things, like proteins, for glycogen. Fat stores will be poorly utilized. We're not going to be using the fat. We're going to be using the proteins from our body. And we're also going to have increased energy and protein requirements. And that's what cortisol looks like in your body. Hooray! Now, if you are malnourished, various systems in your body are going to be affected. Now, this is a new topic. We've moved on from stress. Stress is going to affect every system, long story short. Effects of malnutrition, system by system, you're going to have deficiencies that can lead to destruction of tissues. That's the simple way to look at it. If you're in your cardiovascular system, you can develop cardiomyopathy, especially like a dilated cardiomyopathy, kind of like what we saw with Graves' disease, right? You strip yourself of nutrition when you're not getting it from external sources. Cachexia is a form of malnutrition specific to protein wasting. That's what cachexia is. I think I've got a slide for cachexia coming on. Let's think about refeeding syndrome for a bit. I've got a sad, horrible story for you. That's what patho is, a series of sad, horrible stories. But this one's especially horrible. So Auschwitz, concentration camps. A lot of people were in a state of starvation when World War II was over and we released people from Auschwitz. A lot of people were waiting on the other side of the doors for these people. Welcome, congratulations, you're free. They're waiting there with candy to give to these starving people. The sad outcome of giving somebody candy when they're in a starvation state is that they can die because of refeeding syndrome. So some people on the first day of their freedom, in a very long time, after years of absolute horror, was death. And here's why. When somebody is in starvation mode, they are deficient in a number of nutrients. Not just glucose, not just fats, not just carbs. not just nucleic acids or amino acids, right? They're deficient in phosphates and magnesium and potassium. So they get food, insulin secretion goes up, glycogen goes up, protein synthesis. Suddenly, we have this income of nutrients our cells can start to metabolize. They get excited, right? Not like real people, but as much as cells can get excited, cells get excited. They can start to rebuild all the damage that's been done from years of malnutrition. So you have uptake of glucose. And then you're going to take any and all available phosphate, potassium, magnesium. You're low on it already. You're going to take it from your body. And you're going to try to start to anabolize. You're going to try to start building up, utilizing these things from your body. You're going to take them from other places. You're going to end up with hypophosphatemia, hypomagnesemia, hypokalemia, thiamine deficiency. It's kind of like if you took up the floorboards to fix the windows, right? And that's what refeeding syndrome is. And this is going to be a little slightly different description than what's in your textbook. I like this one. So when we do give somebody nutrition after a period of starvation, that has to be introduced slowly and carefully with a mind to electrolyte balance, nutrition, minerals, vitamins, not just proteins, carbs, lipids. Yeah, kids in Ethiopia. Right. Yeah, all of these well-meaning people shoving candy and food into the hands of starving kids. It's well-meaning. Like, I think it's going to be pretty quick. I don't know how fast it happens. Heart failure pretty quickly. Yeah.
Because the moment you pull all the potassiums and magnesium away,
so like one of the meanest things you could say to an anorexic is eat a cheeseburger, which people love to say to you.
Yeah, don't tell an anorexic person to eat a cheeseburger. It's a bad plan. Right, that makes a lot of sense, that you just have sudden heart failure from the electrolyte balance. Yeah, and imbalance. Okay, it's kind of in a weird order. We already said effects of malnutrition on the cardiovascular system. It can lead to cardiomyopathy. We only went into refeeding because it's referred to there. So respiratory system, honestly, immune system, all these different systems, the pattern is the same. We're going to have gradual destruction of tissues if you don't have the nourishment to repair those cells. That's really all of it. So decreased lung parenchyma because you don't have enough protein synthesis. In your immune system, you're going to have a lack of protein, meaning you can't synthesize new immunoglobulins, interleukins that are part of different immunological pathways. You're going to have an impaired immune system. And I could have a slide for every system in the body that would look exactly the same. Cardiovascular, respiratory, immune, integument, impaired healing, impaired protein synthesis, degradation of tissue. Are you guys okay with me powering through since there's 6 slides left? Okay. All right, the last part here is altered states that will change your nutritional requirements. And I know this overlaps with a bunch of other courses, so I'm not going to beleaguer it too much. If you have an infection, if you're battling sepsis or fever, your basal metabolic rate is increased. There's maybe some old wives' tales out there. Maybe you need to starve a flu or something like that. That's never true. If you're sick, give them more calories. They have to fight the infection. So additional energy, and when we say additional energy, we usually mean glucose, right? Most simply, we mean glucose. Maybe we need fats. Amino acids for immune response because you need to make immunoglobulins. And then as needed to prevent depletion. That just means pure calories. If somebody's had surgery, they're going to need a lot of protein to repair the damage. After an operation, their metabolic rate may increase by 35%. So we're going to need significantly more calories. And why this is significant to you again is maybe somebody's battling their weight issues. Maybe somebody's been on a diet and then they have surgery and now you have to convince them to eat more, right? It's a challenge. Protein required after wound healing in general. Trauma, again, basal metabolic rate increases by as much as 30%. And it's a sudden stress, so there's going to be a lot of breakdown. You're going to have a lot of catecholamines if there is a trauma, lots of epinephrine and norepinephrine. So you're going to need, again, more carbs, more proteins. I mean, basically the takeaway is you need more nutrition. And for burns and cancer, there's some extra complications here. So your metabolic rate is going to greatly increase after a burn, as much as 100% increase. You're like double our basal metabolic rate while healing from burns. And that's massive. However, what we're going to learn about in week 10 is that burns have some other complications. One of them is protein denaturation. Those proteins can go to the kidneys and cause kidney damage. And if your kidneys are struggling to recover from a burn, and then we give them a bunch of protein so that they can heal from the burn, we could be causing extra stress to the kidneys. So that's going to require very special monitoring. So indirect calorimetry means that we can determine how many calories they're spending and then replace exactly those calories so that we don't overstress their system. That's working to repair the kidneys. Cancer has its own concerns as well, some very special cases here. So during cancer, first of all, the tumor is going to use your nutrition. If you're eating a lot of sugar, your tumor is going to use a lot of that sugar. So some people battling cancer are going to go on some very special diets to limit tumor growth. But at the same time, if there's cancer treatment, such as radiation, such as chemotherapy, that's very destructive to tissues, that's going to require a lot of wound healing and a lot of protein. At the same time, that treatment is making that person very nauseous, and it's probably making them vomit a lot. So they're going to be malnourished many times over. And our nutritional support is going to be difficult to achieve. It's going to be hard to give this person enough nutrition when they're just going to vomit it up, when they don't want to eat it, and when it's not going to help them, it's going to help their tumor anyway. So there's a lot of extra treatment and considerations here. Also, again, there's this idea of cachexia, which is specific to protein wasting. Okay. Finally, with immobility, for whatever reason, immobility has multiple causes. It could be sedentary lifestyle. It could be de-innervation. It could be because you have a health status that means that you can't exercise very effectively. If you're not putting weight on your bones, you will experience bone loss. And that's kind of it. Tissue mass is decreased from disuse and atrophy. Muscle mass is going to go down. Bone loss is going to go down. So even though this person is sedentary, again, their nutritional requirements may be increasing because they're losing these nutrients from disuse. And that's it. That's the lecture. Any questions before I stop the slides or before I stop recording? Nope. Okay, great job.